which invade various countries, and they will continue to happen, will make those countries experience economic, political, and social shocks of public health in a manner you witnessed with COVID-19. The first case of COVID-19 was reported from Hubei province in China, and within 3 months, it was a pandemic where on March 11, 2020, it was declared a pandemic by the WHO. Here, our first case was on 12 March 2020. Now, when the disease was with us, the health workers had a lot of fear on handling the patients. There was a stigma, discrimination, and the patients experienced lockdowns and travel restrictions. So the WHO and the ministries of health encouraged the patients to attend to health facilities for important services. So from the foregoing, it was important to investigate whether there were any negative effects in our county with regards to the health services on maternal and child health. So this study compared 2 years, 1 year before COVID-19 and 1 year of COVID-19. The aim was to examine broadly the impact of COVID-19 on MCH services and give recommendations. It was ethically cleared. It didn't have much on ethical issues, but we were cleared by the Meru University of Science and Technology Review Committee. We reviewed the health records within the 2 years before and after COVID-19, and went ahead to triangulate the information found with data from focus group discussions and the key informants. And we did the analysis using SPSS. The results? We did not find any significant differences in the overall coverages of BCG. BCG is the first antigen to be given to newborns. Although it varied within the sub-counties, overall there was no significant difference. Now, the population of 1 year fully immunized children during the 2 periods did also not show any changes, as T at P less than 0.5 was 0.098. The proportions of pregnant adolescents 10 to 19 years, 12 months before COVID-19 to 14 months during COVID-19 period did also not significantly change, as P was 0.83. However, the proportions of the antenatal care visits 12 months before COVID-19 compared to the 14 months of COVID-19 period differed, where you find that T26, P equals 0.01. So there were higher monthly visits before COVID-19 in this case. However, The proportions of the fourth antenatal care visits 12 months before COVID-19 compared to 14 months of COVID-19 period significantly different. And you see P is equal to 0.01. Nevertheless, the proportion of teenage pregnancies 10 to 14 years presenting with the pregnancies during the first ANC visit between the two periods demonstrated significant differences during and after the pandemic. And T26, P was equal to 0.003. That is a table showing the number of children, adolescents between that age per sub-county. And what you can see there is that there were sub-counties with the higher numbers of pregnant adolescents during that period. And the highest was Imenti North. And if you look at Imenti North, this is where Meru municipality is situated. It was followed by Gembe Centro. Gembe Centro is where you have Kangeta. It's also a coming up urban center. And then Gembe South, which also houses Maua Municipal. So the total number of adolescents who were pregnant in the first ANC visit before COVID-19 were 334, and slightly more than a third were reported in Gembe Central Sub-County. During the pandemic, 1,700 adolescents presented with pregnancies on first ANC visit. And I've seen here the highest was Imenti North, followed by Imenti South, and then Gembe Central. The proportions of pregnant adolescents presenting with pregnancies on first ANC visit during the two periods were significantly different at P equals 0.003. A bit of discussion here. The proportions of BCG coverage between the two periods different, although this is irrespective of the fact that BCG is given on first contact with a neonate. This could have been because of children born at home, because of the travel restrictions, fear of attending health facilities, because people thought they might be infected within the health facilities. Those are some of the reasons that came out from the focus group discussions and the key informants. However, the variations in the intra-sub-county coverages did not affect the overall performance, which was, the P was 0.29. Now, the fully immunized child or children who had received the BCG dose, 3 doses of DPT, Hep B and HIV, and 3 doses of polio, 1 dose of measles, 3 doses of pneumococcal vaccine of between the age 12 to 23 months, different across the sub-counties. Again, the reasons were lockdowns and the fear of attending health facilities. The overall fully immunized child proportions did not significantly differ between the two periods, where you find that the P is equal to 0.098. But we recommend mop-ups in sub-counties that experienced hiccups in the changes of the proportions, which, according to the previous performance, were still okay. However, the no change that there was in Meru County arose because many mothers also thought that the real vaccination of children would also protect the child from COVID-19. So they continued taking the children without the knowledge that this is not COVID-19 vaccine, but other routine vaccines. But it worked for us. So I would say this, my findings also correspond with those of others. There is the Said at Eto 2022 who reported improved vaccination during the pandemic. I think this was in Pakistan. And again, like in North Imenti, the mean proportion of fully immunized children before COVID-19 was better compared to during the pandemic. Again, this corresponds with the other findings of AXIA 2020, RANA 2021, and McDonald 2021. The reasons for lower coverages were related to lockdowns, travel restrictions, fear of nosocomial infections. Nosocomial infections are infections that you may get when you visit a health facility, which are not your initial disease that you went for treatment. So in spite of this, other sub-counties experience no significant differences like found in other studies. And the study here is that one of Lusinde, which was conducted in Kilifi. Conclusions and recommendations. Overall, COVID-19 pandemic did not fundamentally affect MCH services the first year of sickness increased. So there is need for stakeholders, parents, churches, teachers, and the Ministry of Children and Gender to examine the root cause of teenage pregnancies and curtail these proportions. Thank you. Those are the references. And this study was funded by Meru University of Science and Technology, which I'm thankful, and would expect that it will assist us upscale the health services in our county. Thank you.
Thank you very much, Bwana Miriti, for that those insightful results from your study. We really appreciate this because this is about what is happening in areas where we're staying at the moment. At this juncture, a few comments or questions are going to be directed to you, and I open this forum for questions and comments. I invite anybody who may be having a comment on the study. Good. I think I can go with my question. Merit, you have already shared with us various statistics that indicated majority of them were not significant in terms of the differences. But as we were indicated the other day, it is always nice to indicate the statistical method that was applied in order for you to indicate the significance or non-significance of the differences. For instance, I look at antenatal clinic visits. You indicated that it wasn't significant between various period, between the 2 years before COVID and 2 years after the COVID. It would be interesting to determine why we had the non-significance when we knew that there were certain restrictions in terms of the movement, in terms of presenting yourself to the health facilities. There was that fear which made a lot of people to stay away from health facility. The second thing that came to my attention is that yes, we are seeing these non-significant results, but non-significant result may have been as a result of differences or the level of COVID-19 that existed in the study areas where you undertook it. So what was the levels of the COVID in the facilities where, or in the area where this study was done, because that would have a lot of relevance into it. The third question that maybe we can look at is that you have indicated there were quite a number of women who gave birth at home, meaning that their newborns may have missed the chance of having BCG as the first contact vaccine, or it may have been given after some period of after birth, after some period from birth. The issue is that any chance that you may have looked at how good this BCG worked, because we know the sensitivity of BCG depends on the many factors, depends on when it is given, depends on the site. So if you can go to those questions, maybe we can shed more light to this, or we can...
Thank you, yeah, Prof, for those good questions. The first one is the statistical method that I used to do the testing. I used 2T to compare. The student 2T. Then there was the second question, which was to determine why there were no significant differences, yet it was during that period. One of the characteristics of the access of health facilities in Meru is that the facilities are closely accessible to most of these people, even where they are not, even where they are to use transport. The facilities we got from the stakeholders is that they are closer to the people. Roughly, it would be about 80 kilometers. And these are areas which could be accessed through motorbikes, and the others, people would walk down there. The other one is that the mothers thought the vaccination was meant to protect the children from COVID-19. So those are the probable reasons as to why there could not have been significant difference even during the COVID-19. The third one is the COVID-19 cases in the sub-counties. There were a case here and there, and these are the ones that were causing fear, but it's only within 3 sub-counties that we did not find any significant difference. So the last one is the BCG, the missed BCGs. This one, the BCG is given at birth. And for those who missed the BCG, they were either born at home, of which through the community health workers, they are supposed to visit the health facility. Immediately, the chief gives a birth notification. Thank you.
Thank you very much, Dr. Meriti, for that very insightful, those insightful results. Let us appreciate Meriti in a big way for the good presentation. Let us, again, big clap, you know. Thank you very much. We now move to the next presentation by our colleague, Capigan is with us. Again, like we said, we want you to take as short period as possible. But based on the conference, yes, we would allow 10 minutes and 5 minutes of questioning or comments. Is Peter Antoiti here? Thank you, sorry for, okay. Then you line yourself next to, after Capigan. Millicent Capigan is a colleague of ours. She is currently the chair of nursing department. She's been working with us for a while, and we really look forward to listening to our topic as the role of stakeholders in the clinical training of undergraduate nursing students. She will unearth issues that pertain to the challenges, the high points of our training of nurses based on the various health facilities around here. Thank you. If we are having some challenges, or it is there already. Thank you.
Thank you so much. And okay. Good afternoon. Yes, I'm Millicent Capigan, just as you've heard, and my area of passion is training of nursing students. I carried out a research on the role of stakeholders in clinical training of nursing students, and this research was done under the supervision of Professor Simon Kangete of Moi University, the late Professor Anna Karani of Nairobi University, and of course, can say, may her soul rest in peace. And this study, what prompted the study is because quite a number of people would start thinking about the challenges that we experience when we are training the nurses, and very little has been done on the roles of those people, the stakeholders who are responsible for the training of these nurses. And you realize that these roles may not be obvious. There are some detailed roles that may actually facilitate the training of these nurses and effectively. And so we always look at the challenges, not looking back and seeing whether the people, the stakeholders, are really aware of their roles. And so the study was done. It was part of a larger study, which actually, so this part, we'll be able to see some few things, and we'll realize that we are very much aware of the obvious roles, and there are some subtle roles that some of our stakeholders are not aware about. And we'll go straight into the what I call introduction, which covers actually quite a number of parts of the research. And starting off, nurses are one of the main healthcare providers in the healthcare system, and we know very well. And we are told that they form the backbone of healthcare services, representing over 50% of the health professionals, which actually we can attest of that, because when we go to hospitals, we find quite a number of them. And they spend longer hours with the patients, and so they have to be adequately prepared for their role. And this begins in the training of these nurses. So that's what I've just said. The services begin with the training of these nursing students. So the quality of the training determines the quality of the competency and performance of the nurses whom we graduate out into the market. Nursing education is dynamic, continuous learning process of acquisition of knowledge, development of skills, and subsequent change in attitude and behavior in the desired direction. So you realize that the training of nurses is just like the training of any other learner, teaching of any other learner. We have the knowledge aspect, which they acquire in class, and we give them all the knowledge and everything. They also have to develop their skills. Yes, and of course, for a very long time, nursing has been a competency-based career or profession. And they really have to perform the skills. They spend a very good period of time in their skills laboratories or in the clinical areas. And so they have to develop the skill. Without that skill, they may not perform very well. And also the development of the skill is very, very important because of whom they are dealing with. And that is the patient as a person, human life. And therefore, they really have to get it right. And also, we have that, attitude aspect of the training. They really have also to have the right attitude. They may be knowledgeable, they may be with the skill. With the wrong attitude, things will go wrong. And so they get these parts. It's dynamic, keeps on changing, and the nursing training depends mainly on the societal needs. And that is why there is that dynamic change, especially in education, because it's almost like the society dictates exactly what the nurses do, and therefore dictates also what should be in the curriculum for their training. And in this case, one of the most critical experience of nursing students is exposure to patients in the clinical setting during the training, and that is the clinical learning environment. The overall objective of the clinical practice for the nursing students is to graduate, for the nursing training, is there to graduate those students who are able to carry out nursing care efficiently and effectively. Yes, that is exactly what we want, because if they miss it in the training, it will be very difficult for them to get when they are already in service. This implies that nursing students should be able to apply scientific approach to nursing, from initial assessment to the rehabilitation of the patient or the client. That is from the start, from the admission to discharge, and even at home during rehabilitation, because that's where rehabilitation takes place. A positive and enriching learning environment definitely can provide a positive, learning environment. This is possible with the availability of nurses in the hospital who play an integral role in supervision, mentorship, preceptorship, and relationship development between the nursing students and other healthcare providers. And this is very important. And one of the roles of nurses is being a role model, one of the many. They have so many roles, including role modeling. And so, if they don't get the right training, they may not be very good role models when they are once in service, because they'll be supervising, they'll be mentoring, preceptorship, relationship development, and all that, where you realize most of the students learn them by seeing and by emulating and following what is happening. It's not only what you've been taught in school, but you also see how others are performing. And that's how most of the nurses learn. So if we don't get the right people who have the right qualification, the right performance, right procedures, the students may miss it. The clinical teaching is carried out by the educators who liaise with the clinical nursing staff in the hospitals. So we have had the nurses who are the role models, the educators who are the lecturers, the clinical instructors. They follow up these students out there, and they liaise with the nursing staff in the training of these students. And educators are responsible for the integration of the theoretical knowledge and practical skills in the clinical setting. And this is done by monitoring the completion of assignments and accomplishment of outcomes amongst many, many roles. The relationship between the higher education institutions and health service placement providers impacts upon the quality of clinical placement as well. And so, to optimize the quality of these placements, it is essential that the institutions provide appropriate support to the practice nurses mentoring these nursing students. And in this study, the nurses, nursing students, educators, and the administrators from the hospitals and the training institutions formed the population that was used in the collection of the data. So the purpose of this study was to find out the role of these stakeholders in the clinical learning environment, and we opted to find out from they themselves. Let them tell us what is their role, so that we are able to tell whether they really know their role or not, and will help us in designing our curriculum, setting objectives, and organizing inductions and many other things. And therefore, these findings should be able to support the ultimate goal of training by guiding the planning and the induction of those trainings. The study actually, this aspect of it utilized the descriptive cross-sectional design and to involve the collection of the data from different categories of respondents, whom I have actually mentioned as the nursing students themselves, and then the nurses in the hospitals, the educators from the universities, and also the administrators from those universities. And this was carried out in 4 selected universities, which I can namely say the Kenya Methodist University, Chuka University, Dedan Kimathi University, and Kenyatta University. And 3 selected hospitals, which were Nyeri Teaching and Referral Hospital, Meru Teaching and Referral Hospital, and Chuka Sub-County Hospital. So the population, as I've mentioned. So data was collected using self-administered questionnaires and an interview schedule, where the questionnaires were given to the nurses, the nursing students, and their educators, while the interview schedule was used for the administrators. And the data was analyzed using the SPSS database. So the findings, briefly, out of the 173 nursing students, 100% of them knew that they are supposed to be doing assignments, they are supposed to apply theory to practice as per the objectives. That is what they knew. The other spread out, of course, 131, which is 75.7%, indicated that their work was to interact with other health workers in the clinical areas. And of course, these responses are in agreement with the Nursing Council of Kenya that requires them actually to carry out the assignments, to administer the medication, provision of nursing care, and also documentation of the nursing care that has been provided. And this, our Nursing Council, of course, we know, ascribes to the International Council for Nurses. So this is what is expected of nursing students worldwide. So the graph shows us the responses. So doing assignments was 100%, and also applying theory to practice. We had those who say they were to report in the ward. It is their work or their role to make sure they are in the ward as scheduled. That was about 86.7%, while another 100 said to care for patients as per the objectives, and the group that said to interact with the workers. And then for the nurses, we had 137, which is out of 140, that's 97.8%, indicating that their role is to welcome and orient students as they report to the clinical placement. And then 30 out of that 140, that's 21. And that was all. So, of nursing students is what this by Arabia. That. And so you realize several other responses. For example, there were those who said they are to welcome students to them, to the ward. That is about 80%. Those who are to countersign the students' documents were about 89%. And then interacting with students in a friendly way, it was about 92.14%. And 83.57% were to assign students duties as per the objectives. And so that is what the nurses said they know their roles to be. For the educators, there were 23 of them. And these educators were mainly those who were directly involved with the learners in the clinical environment. And so these ones indicated that 100% said that they were to assess students and solve any issues that are arising in the clinical environment. 35.7% indicated that their role is to hold conferences with students, which is actually something very significant when we are training our students. So according to Jamshidi et al., 2016, in her study, they did this in Iran and said lecturers need to help students develop critical thinking skills to maintain and enhance their competence, which you realize that quite a number of them did not bring that out very clearly. They had so many responses, and you know that nothing came out close to developing critical thinking. For the administrators, they said that theirs is to liaise with the training institutions, that is, liaise with each other. The hospital administrators to liaise with the training institution. And only one of them, out of the 7 that I interviewed, only one is the one who was able to say that they were to liaise. The 3 said that their role is to obtain MOUs between health facilities and the universities. In conclusion, since clinical training is very crucial in nurse preparation, the role of these individuals who are involved in the clinical training aspect of the students must be clear, must be very clear, and they must be aware of that. So failure to do this definitely will jeopardize the training, leading to graduation of incompetent nurses or those nurses who will not fit into the job market. Stakeholders, as I said, and according to the results of this study, every stakeholder could identify some of the roles they play in the clinical areas. But you realize that they are subtle ones because we look at our learners as a whole. There is the physical, there is the mental, psychological, spiritual, and all that did not come out clearly. And it's important that students are clear in their roles and other than application of theory to practice. And the recommendations, this study recommended that with the results obtained, educational policy makers should focus on improving the clinical learning environment. That's now from the training institution and the hospitals. When they are considering the training of these learners, they should consider the improving the environment. They should also identify professional models and increase the influence on management, education, and clinical education, as well as teaching positive and constructive strategies will promote the strategies in coping with inadequate educational context. And this is necessary for the professional development of students. And these are the two references, but there are so many others. Thank you.
Thank you very much. Thank you very much, Millicent, for the good presentation about the role of nursing and the stakeholders. And I think this is a key. Let us appreciate Millicent for the good presentation. With that, we open the floor so that if anybody has any question or comments, then Millicent can act on it. Yes, Peter Ntoiti.
Thank you very much. I think that's a very good presentation, Millicent. Perhaps something I wanted to know, since you talk about the role of stakeholders. I think this study is very timely because the CPC that's upcoming, the competency is a very key aspect that's being emphasized. We know sometimes when the stakeholders are performing their roles, they might find certain challenges, and I was wondering if the stakeholders reported that they were willing to perform their roles in terms of training of nurses, but perhaps they faced certain challenges that perhaps need to or that may require to be taken through intra or inter-institutional efforts to be able to deal with. Thank you.
Thank you so much, Millicent. Also, I just wanted to add on the willingness bit of the... Sorry, my name is Maura Esther, an MSc student. I just wanted to contribute also on the willingness of the stakeholders, because they know, yes, it's their role, but are they willing? What are we doing to the stakeholders to ensure, despite that it's mandated to them that they should train the nurses, are we doing advocacy? Maybe that one could be one of the recommendations, because we need to do advocacy also to the stakeholders for them to be willing to teach also the nurses. Thank you.
Thank you, Doc, for that great presentation. I'm Thomas Atenya, an MSc student, and my question is, your study is so important because it has put together the stakeholders who are involved in training these nursing students. But I have one question or one concern, because most clinicians or nurses, when they graduate, they just want to be clinicians or practice. Very few who come out like you to academia or further their studies, and you see they are in close contact with patients and they understand the shortcomings that are in hospitals, like AMR, ineffective medications, that they are therapeutic interventions. as compared to other parts of the world where clinicians and nurses are involved in serious medical research, to now find out if this medication is not working for my patients, I think I should do something or tackle this AMR issue to now assist my patients. What are you as trainers and stakeholders doing to incorporate or to make them love also the scientific bit, not the clinical bit alone, so that they can be all round and also be able to tackle the issues that are affecting their patients directly?
Okay.
If I can respond to those questions before we can ask some more questions.
Thank you so much for the questions, and I'll start with the first one on the challenges. Actually, the study was actually a massive one that had 3 objectives. One was the roles. First of all, we understand the roles of these people and if they are aware of those roles. And then the second was to look at the challenges for sure that they encounter. And of course, yes, they have challenges, and that was a different objective from this. And it came out very clearly, what those challenges are. And that question is tied to what he's saying. Actually, what do we do to tie them to research, to clinicals, and such kind? And that comes out in mainly in the challenges. Because the moment, first of all, when we realize that some of them are not aware of their roles. For example, part of the demographic, information we obtained was asking them if they have, how long have they been involved in the instruction of the students, directly, involved. And some even had 1 to 2 years of experience. The majority had 3 to 5 years. And then you realize that those who could have been senior, 7 years and above, were just some few, very few. And so another question in that demographic part was asking them whether they had gotten an induction in the training of these students. And sincerely, about 23%, now in total, 140 nurses, 23 educators, 23% of them were like, we've received that induction. Where is the other? Where are the others? The others is like they're learning on the job. And who is teaching them? Almost no one, because it seems there has not been any induction, no training, no in-service on how to handle these students. And also, initially, if you look at the history of nursing training, as with the levels were getting higher and higher, part of the responsibilities of a nurse in the world was to train the juniors, train the students. So if you are qualified, you train the students. And that one is found in the scope of practice, mainly from the Nursing Council of Kenya. But so they come to school, they are trained, they are graduated, they go to the field, and while they are there, nobody follows up to do the induction. Yes, so the knowledge they have is probably from what they saw their own teachers and instructors seeing. The knowledge that probably they would have about instruction of students is their own experience when they were students. And so you find that, true enough, there is the other part of the study, and it's looking at the challenges. Yes, we have, recommendations, and I appreciate that one. Yes, canvassing, and probably, I think the best word we can use is actually induction. Yes, if we can plan for a training or an induction of all our nurses in the hospital, all our nursing lecturers and clinical instructors, then that is as good as canvassing or, campaigning, reaching to them. And so that is a recommendation that I had made, that this study would really help us in planning the induction of these stakeholders. Yes, some even in them, of the administrators, they were able, the majority in fact were able to say they budget for clinical training of the nursing students, and also they just sign the MOUs or acquire the MOUs, and that's all. But they have a whole lot of responsibilities. What is happening with those students once we send them out of our training institutions to go to the hospital? Are they aware, and do they have any role to play? And so, yes, that will really help us, and it's a recommendation that we plan an induction or a training, a retraining for those stakeholders. Thank you.
Thank you, Millicent. But
excuse me, let me clarify something. For the other question, you'll realize that in nursing we have so many branches and areas of interest. And we have people, yes, who have been very much interested in research in our nursing. I think you might hear even some of our presenters who are in nursing presenting some of the research they have carried out. Yes, in nursing care and responsibilities of nurses in the hospital, yes, when it comes to issues of cancer or issues of the corona. There are people, nurses, who have gotten into there and they were trying to find out what was our role or how did it affect us as nurses. And then of course we have the educators who are nurse educators like me, where we are really working on the training aspect. Yes, either in the classroom or out there in the clinical areas, and many others. Yeah, thank you.
Thank you for this. Now I've got I don't know whether it is a question or a comment. As a profession, nursing is about attitudes. It's about the way people practice and the competencies that they eventually acquire. But if you listen to majority of those who are receiving these services, they have complaints, particularly those who are incapacitated. The level of the nursing care that is given to them by the nurses. Now, the issue is it because they have not, the supervisors or those who are supposed to give them this competency and skills for nursing has not been done? Or is it something that people develop out of heart care for those who they know that they are incapable of assisting themselves, in your experience?
Thank you, Professor.
The second question, and related to that, and I think this is, I don't know whether I can classify it as a loose talk. It is very common to hear mothers who are in delivery wards complaining about the treatment or from the nurses. Again, what is it that we are missing in their training which would make even those who require the service at very critical times be feeling that these are not friendly people, particularly the female nurses, for the mothers who are delivering? I think you've heard of such loose talk. Is it true, or is it that they miss something? How can we improve it? How can we tone it down? Thank you.
Thank you, Prof. And you realize that two of your questions is just but related, very closely related. And very closely related because it is more of attitude. And that's why I mentioned that someone may have the knowledge and the skill, perfect, but with a wrong attitude, it messes up everything. And we know very well, those of us in the training sector, education sector, that attitude is very vague and elusive. It's an elusive concept. Training, teaching someone to change attitude, teaching someone the right attitude is something that's quite tricky. But in the education sector, every learner should acquire knowledge, know how to perform the skill, and also develop the right attitude. Now, when it comes to that attitude, you will realize that we have a problem with the training of that attitude in the first place. And now that you are saying it's a loose talk, I may also not support with some data right here, but from my experience, as you had mentioned, you realize that telling them exactly what to do is very crucial. It is tied to the close supervision, which if we look at what I had here, the data that I had, it did not come out very loudly that I have to avail myself as an educator and stay very closely to my student a good part of the time. It did not come out very clearly. Yet, in the studies, it shows that the instructor, the clinical instructor or the educator who is in the clinicals with the learners should avail themselves. Even if I'm here in Injiru, I get a call in Meru level 5, a student is saying, Mwalimu, I got an issue and I have a patient. I should be able to jump and get there and, discuss the issue. So you realize that it may not be possible. So we have many things surrounding this training, which actually may lead to what you are saying. Probably nurses not being friendly in the ward, probably nurses not handling the patients well, and all those loose talks. And you realize that it is basically probably because we have, of course, the starving factor on the other side, which in the challenges, that came out very, very loudly. And we also have starving factor on this other side. Yes, our university is able to actually employ and give enough clinical instructors. And you see, the minimum number we would need are 5 clinical instructors at a time as per the areas of specialization in nursing. So you see, if, like now, there are institutions who do not even have, they use their lecturers, classroom lecturers. You teach in class, you run over to the hospital. And so you realize that there are so many factors. So we have not really had a grip of time to really work and monitor. And as I finish, I can say many a times, I always say, when we prepare nurses, we work them into nursing. As a nurse, I should take my student and work with them into nursing. Yes, and as we work, that means I should be with them, see what they are doing, prepare them, watch them as they go. I don't leave them until when they finish. Thank you.
Okay. Before I give the mic to the next person, I'm very happy that you've brought one matter which is critical in nursing. And I'm also very happy to see to it our DVC is around. DVC, what she has indicated is that there is need for more clinical instructors at the nursing level, or nursing training. So we could liaise with his office and see how we can at least get more clinical instructors, because attitude is everything. If we don't change their attitude, then we know even the care that we are going to give is not going to be at optimal.
Exactly.
Thank you.
Thank you, Prof, for that campaign for us in nursing.
Thank you, Kapigan, for the nice presentation. Mine is specifically on training, because we are in it, and we are in 21st century where we require more stakeholders. So I want to know, have we been able to fill the gap of integrating technology and the training, whereby technology is really moderating how we perform our duties in the clinic or on the bedside? Because you find a clinic officer or a nurse practicing and multitasking with technology. Where does the paradigm stop when it comes to training, technology, and our care for the patient? Because we require technology to deliver care, we require technology to do everything. But what are we recommending to the gurus who are manufacturing this gadget? Because we are not able to separate social media, clinical care, and the patient, because it is a very tricky area. as we churn out these graduates outside, we're having a lot of challenges for them to control the use of technology in the sector.
Thank you, Dr. Kubai, for that. Yes, technology is with us, and we cannot deny that. Technology has its own advantages and disadvantages, definitely. It has affected also the field of health, and you realize that the technology, positively, we are shifting. Well, currently, if you go to quite a number of hospitals, they've tried, going high-tech. So you find that we no longer run around with the patient files from one office to another along the corridors and such kind of things. And from admission or reception, when they are entering into the computer, they only walk to the different destinations and already the information is there. And so that is a plus, and we have gone that far. We have some of our, training hospitals, the ones we send our students to. Some of them do already have connected that. And students are also, when they go there, they're given a password, they're able to access, they do their documentation there, they do their signing in when they have administered medication, and they write their nurses' notes there. And so, that aspect of it, yes, we are trying to really get it there. We are encouraging them. If you also look at some of the information that we were trying to obtain, and that especially fell under the challenges, was whether we really have the resource, learning resource center for our students, whereby we have internet, we have reference books, updated ones, we have, a laptop or a desktop that they can use, and such kind of things. And you realize also that area was a little bit wanting, yes, and so you realize that it is part of it. Now, on the other side, on the other hand, we have the phones, and I think that is exactly what was mainly. And mainly what you are interested in getting to hear, where students, you find that when they are in the ward, they are very, very busy with their, their handsets, their phones, and they compromise the patient care. With the same close supervision, we may be able to overcome that. If we have clinical instructors very closely watching them, their, lecturers who can go to there, who should actually, ideally they should be there to see the students. Of course, a student will not adamantly hang on to the phone when they are seeing their teacher, their instructor there. And so, supervision, close supervision, availability of these supervisors is actually everything. That will help us in this. We've had rules and regulations which actually in policies and guidelines that we give students in the clinical areas, that is what the hospitals actually come up with. And we've had some of the hospitals which are strict enough to even confiscate those phones. When they get a student with the phone, when they're supposed to be providing nursing care, they are confiscated. I have known of a hospital where it is a policy for all staff, wherever you are, walk through the gate and the phone should be silent. Nobody is allowed to receive that phone. And it worked. It's very interesting. They know themselves because I know they know me wherever they are and they are hearing me. Yes, and it worked. And when you are found with that, it is, you are disciplined. Even if you are a doctor, you are a qualified nurse, a clinical officer qualified, a student, even if you are a medical staff, as soon as you come into the hospital premises, your phone should be silent, you switch it off until when you go out. So we are trying. Yes, much as, yes, we are getting overwhelmed, but we are very much aware about that. Thank you.
Okay, Chair, allow me to make a contribution.
Yes, go ahead.
Yes, Vincent, sorry I came a little late, but I had a few comments. Mine is, one is patient-centered care, and how the nurses treat us, me as a potential patient, versus the behavior of nurses in other countries, looking at the Kenyan nursing and other countries, we're trying to introduce this course on patient-centered care. Because many of the people here, I heard Prof. what he said about those mothers going to deliver and the kind of language. But even us, when you go and you're being treated, whether nurses or doctors, some of them, even before they listen to you, they have prescribed. Even looking downwards, they are not even looking at you to take the signs. Patient-centered care, not nurses-centered care, is something that we'll be discussing. The other issue is the issue of language. We are training for Kenya, for East Africa, for the whole world. And I don't need to mention to you what happened to our nurses when they did the entry English language to go and work in the UK. And we have shortages of nurses in Europe, in Australia, in Canada, in the US. So you would comment on how you are preparing our nurses to work abroad and be a source of remittance back to our country, because we know diaspora remittance is a key part of the economy of this country. Those two items for you, Millicent Kapigan. Thank you. For the other one, I heard, Prof, about shortage of clinical instructors in nursing. That one is something that the management is going to take care of, because we want our nursing program to be quality. And we churn out nurses who are of international standards. So that one I had, and we're handling it at the management level. Thank you.
Thank you, Prof, for that. And I think in a very brief way, I can say it all boils down to supervision. Yes, what he said, what you are saying, preparation of our students to go international and fit. I know curriculum is actually a curriculum that should be able to prepare our students to be international graduates in the long run. And close supervision is all that is required. To change that attitude, we need close supervision. They pick these funny language, funny ways of handling patients, especially when they are left unattended. And just as we know very well, a good percentage of human character and behavior is acquired by watching, observing. So when they go there and they get the wrong role model, they pick from there and it spreads like a bushfire. And so when we closely monitor them, we set the standards very clearly. And that one I have no doubt. The standards are very clear because all our standards are centered in the Nursing Council of Kenya. We have no standards that are not approved by this statutory body that has been appointed by Parliament to implement the Chapter 257 of the Laws of Kenya, which is dealing with nursing. And so standards are very okay. Now it is all about us down here and supervision from the training institution and also from the hospital. And when the other aspect of it, which was the challenges, it was mainly like some of the hospital administrators were saying the university is not giving us adequate staff to support us, while the universities were saying, oh, we don't have support from nurses in the hospital. And so if we could really provide, as I said, the actually minimum number of clinical instructors could be 5. If I talk of 5, those are the 5 areas in nursing. If you look at the medical, surgical, okay, let's talk of medical nursing. You realize that if I have the number of nurses I have, the year 45, 50 actually that the council recommends for us, I need these students to be doing medical experience. They rotate in about 4 areas at a time. So I divide this 50 by 4 and they rotate. That means I need clinical instructors, if it is medical, I'll give an example now. I have students in Kanyakine, Sub-County Hospital. I have in Meru Level 5. 22 in Kanyakine, 21 in Meru Level 5. And they are in male medical ward and female medical ward in both hospitals. Now, if I have one instructor who is to cover both Meru Level 5 and Kanyakine, it's almost like she may not really carry much, or he may not really do much. If I have two, let's say one takes care of Meru Level 5, the other one to Kanyakine. There are two wards, male medical and female medical. This person will still have to juggle between. And at some point, because you cannot go peep and then you run back and peep, you go watch a student perform, correct, and you give the feedback. That means give yourself a minimum of 2 hours. And so that is actually why we feel as if we've not gotten it. We are really trying, we've really tried, and we seem as if we are not getting it. It's basically because of also the staffing, which again is a different aspect of the study. So if we do not have, for example, the way we are now saying we are international, we graduate and they leave. We graduate and they leave, meaning induction from time to time, meaning we'll really need more than enough so that when they leave, we still have a cushion, or we still have a number that can cushion us. And so I want to believe that, Prof, I have given a satisfactory, yes.
Thank you, thank you. I think, yes, these matters can be, we can follow up on these matters because they are relevant, and there could have been other questions that are key, particularly for the languages and how we can deal with them. But for the interest of time, we really want to thank you, and again, let us appreciate Millicent for the good presentation and active discussion this presentation has brought to us. Let us appreciate in a big way.
Thank you, Prof. And I think, yeah, this is a very, very sensitive area, actually.
Thank you.
And
Thank you.
I'm happy that everyone is noticing.
Yes.
And I'm so impressed with the questions, the comments, and I want to believe we'll work together towards this. Thank
Good.
you.
We will always may follow you to make our issues clear to you so that you can improve your program.
Thank you.
Okay, at this juncture, I think for the interest of time, you hold on to your question. Well, I want to invite Peter Ntoiti Kailemia so that he can come and share with us his research. The intersection of social determinants of symptomatic breast cancer presentation in a rural setting, a critical ethnographic study. Peter, welcome, and we're very grateful. Cancer is a big problem in Meru. We really need to get to know what are the things that we are doing or we are not doing in order for us to make it calm down. So the floor is yours. You've got about 10 minutes to give us your results.
Right. Thank you very much, Prof, and good afternoon, everybody. Just, Prof, allow me just to say something about the presentation that has been done. I think training of high-quality nurses, it requires systemic change in this country. The training institutions have to make massive investment, more than perhaps they are making at the moment, and the employers need to create the best conditions for nurses to deliver their services. The same nurses we train here, they go to America, they go to Australia, and they do very well. And we train them here. Just to make that comment. Thank you very much, Prof. and Dr. Juan for this opportunity to present. Dr. Peter Kailemia, the Dean, School of Nursing, University of Embu. But also, Prof, something you do know that I'm part of you because I'm adjunct staff in the School of Nursing in MUST, and perhaps you do know that. There's a study that we did with some of my colleagues in the UK, in the University of Dundee, Dr. Eileen and Professor Emerita Mary. But the study was conducted here in the Meru County. So it's about basically how women present when they discover they have got breast symptoms, the kind of journey they take from the time they make a discovery. And here we are talking about self-discovery. It's not screen-detected kind of symptoms, but it's self-discovery of symptoms and what kind of journey they travel to the first time they get in contact with healthcare professionals. So the two quotes before you captures in a nutshell the subject matter of this study. Is based on an ideology that research that we do is meant to be of use to the people that we do research with. So it's about social justice in healthcare. And those two authors, Michael was among the first to do a lot of studies in the UK about social justice in healthcare, and Martin Luther, who I think we know about, they talked about justice as an important aspect of our social life. At the moment, female breast cancer is at the top. For a long time, lung cancer was, but since 2020, female breast cancer is a highly reported cancer, and we can see what is going on in terms of the numbers. It is increasing so much in the developing countries because there is a lot of transition, both in lifestyle and also in terms of the age. We have got more people living more years, and aging is the biggest risk factor to developing any cancer. So due to these changes, the lifestyle changes, then cancer is becoming a big problem in developing countries. Unfortunately, we do not have the resources. We haven't still sorted out the communicable diseases. So we are facing kind of a burden of disease where we are finding that we are still facing a lot of non-communicable diseases, but still we have not sorted out the communicable diseases themselves. So the outcomes of breast cancer is really bad in low-income countries because the mortality is very high. In terms of the diagnosis, it's being done very late. In terms of the survival rate, it's very poor. Whereas you can see in developing countries, if a lady got breast cancer, they should live for 5 years, 90% of them. But in countries like Kenya and most other low-income countries, you find they are living for quite a very short time. You can see 40% only living for 5 years. So this is very important. Now, the reason for this, the difference for these disparities between high-income countries and low-income is the stage at which breast cancer is detected. That's the most important. Of course, treatment plays a big role, but the fundamental determinant of the survival rate, how many years one actually can live when the breast cancer is being treated, is actually the stage at which it is detected. In our countries, low-income countries, the detection usually at stage 3 and 4, whereas in the developing countries, most of them, they are detected stage 1 and 2, though the survival rate is pretty good. So early detection is basically the solution to this problem. But we have two methods we can do this. We have what is called early diagnosis, and then we have screening. For countries like Kenya, screening is not feasible because of many economical and demographic factors, which means we can't have population-based screening, mammographic screening. So World Health Organization has said, recommended early diagnosis. Early diagnosis is where we are trying to detect breast cancer at the earliest stage for women who are already symptomatic, because most of them, they present when already they got the symptoms. So the focus is, can we capture these cancers at the earliest stage possible? And the basis of this early diagnosis is the women themselves, when they get the symptoms, they should be able to appraise the symptoms, and after they appraise the symptoms, they actually seek help. And my studies was around self-appraisal of symptoms and making decisions to seek help, and that is what we call patient interval, because patients have to detect the symptoms, appraise the symptoms, make the judgment that these symptoms are indicative of breast cancer, and therefore decide to go to seek help, and not to seek help anywhere, but seek help from health facility. Some of them will go for prayers, some of them go to witch doctors. So there is the aspect of understanding the symptoms and making a judgment to seek help in the right place, which is a healthcare facility. There is a lot of gaps in terms of actually what makes women delay seeking help. And this is what my study attempted to fill. And also how all these determinants interact with each other. That is what we are calling the intersections. Because we might think knowledge is going to influence when a woman is going to seek help, but knowledge can be influenced by other factors that are quite important. And my study took an ideological kind of approach in terms of social justice. And I focused so much about a woman's social position, which can be determined by education, the income, and other factors, and how that influences the intersection of those kind of determinants acting on that woman to determine how long time they took from discovery of the symptoms to the time they actually go to the hospital. So this was the study aim, exploring the determinants that influence this, what I'm calling the patient interval. And to meet that objective, I had these two questions, looking at the women-related factors and also women's perceptions about healthcare system factors. Now, the design was underpinned by critical theory and intersectionality. These are important approaches that are based in critical research because they look at inequalities or health disparities. And critical theory, critical ethnography is based on critical theory, which was formulated in the 1970s, and it has its origins from Karl Marx's work on capitalism and the exploitations that comes around with capitalism. So the design was a critical ethnographic qualitative design, which is a branch of ethnography that looks at the cultures and how they influence people's lives. My population was women who had been diagnosed with breast cancer, and also the disclosure recipients. The disclosure recipient are the people, women, disclosed about their symptoms, because I wanted to know when they disclosed about their symptoms, then what was kind of influence from these social networks. So this being a qualitative study, there were 12 women and 12 disclosure recipients, from who then I sampled using what is called maximum variation purposive sampling. It's a form of a qualitative sampling method, which you consider the characteristics of a population and you develop what is called a sampling matrix that enables you to pick the most salient characteristics around the subject that you were dealing with. The recruitment was done in 2 hospitals within Meru County. This was collected using in-depth interviews with the women, and the themes or the core ideas that came from these women, they informed the formulation of focus group interview schedules, which then were applied with disclosure recipients, who are the close persons who these women disclosed to once they discovered that they had the symptoms. They told the people around them and the kind of influence these people have them in terms of the appraisal of their symptoms as well as the help-seeking behavior. Now, interviews were done in local language because of the educational level. Most of the participants were at the primary level of education, so the local language was seen to be the most important. And then once this was done, there was transcription and translation into the English language, and then a bit of data analysis was done because the tenets of qualitative research is that you do a bit of analysis of study together with data collection to inform the subsequent steps. And data saturation determined the sample that was used. The thematic analysis was used to do analysis according to Spencer, and this was an inductive approach where the data informed the kind of themes that were coming up, and the software and Vivo was very useful to identify these themes, and the research team would meet often to discuss about the emerging themes and then have a discussions and then agree what kind of themes. In the long run, 7 themes and 12 sub-themes emerged. We shall see that in the findings. When you see that, I'll give you the reference to this paper. Some of the ones in Kimeru were used to ensure that the study findings and the cultural leanings that was required. Intersectional analysis, where the interaction between different themes or different determinants was analyzed to ensure that this was clear. Ethics were followed clearly. I think that is important. Now, these are the findings. I just comment because of time factor. Now, the arrow you can see, the 2 arrows you can see on both sides. Now, first and foremost, you can see the woman at the center who is defined by a certain social possession. And you can see their determinants, which are described as proximal distal determinants. It depends on the kind of influence or the distance they have in terms of the influence of behavior. You can see there are different levels of behavior influence, and these levels interact both within and across levels. I think that's the most important thing to note, that healthy behavior is influenced by at different levels, most levels, but both within and across the levels. That is the meaning of those arrows this way and that way. It's influenced within and across different levels, and that is important to appreciate. I think just to finish this, there are many and complex factors that influence women's health-seeking behavior, and they keep interacting with each other, and the kind of models available at the moment may not capture everything, so that we need to appreciate that. For us to be able to respond effectively to the delays women experience, we need intersectional interventions that tackle different factors. And that is important to appreciate, and this is actually the conclusion I'm trying to make here. We need the culturally sensitive interventions that are meant to deal with these problems of delays, and that is important. That's the reference. This study has been published, and that's a reference in case you require to understand more of this study. It has been published, and therefore you can understand the findings. Thank you very much. Sorry if I took more time than planned.
Thank you. Thank you very much, Daktari, for the good presentation on a matter which is really dear to us because of the levels of cancer, particularly here in Meru. And this is an issue which is really getting more and more attention because of the increasing prevalence of breast cancer. We really need to appreciate our Daktari for the good presentation, very clear presentation, loudly. Please join me. Now, secondly, I open the presentation for discussion, and anybody can comment or ask a question on what Dr. has shared with us. Yes?
Thank you, Doc, for the good presentation. Yeah, my hand was up. I'm more passionate about cancer of breast and cancers. And as we know, in this community and even in Kenya, there's a paradigm shift in the way cancer management is happening. So I don't know whether in the intersections of cancer management, specifically the breast cancer, we are thinking about the current trends, that is the genomics, for purpose of what we are calling precision medicine. Because diagnosis is coming up, the availability of diagnostic centers is increasing even in our sub-county hospitals, with the government having a policy now in place. So are we talking about the cancer genomics and the sequencing for purpose of understanding the precision medicine, so that we don't go ahead giving people the general chemotherapy and the radiotherapy, which is not specific for the affected cells? Maybe I would want to hear your take in this study. Thank you.
Thank you, Dr. Kailemia, for such a wonderful presentation. And we know that breast cancer is the most common type of cancers among women. And I'm glad that you are looking at issues that actually maybe might hinder early diagnosis and treatment, which really determines the prognosis for this pandemic. So from your study, I'm just curious, I could not be able to see clearly the themes that were coming out, but I'm curious to see what were the emerging themes that were coming out. And at the same time, you're also looking in your study about the interval, patient interval. So I'm also curious to know how much time in your study, from your study that women are taking from self-diagnosis now to the actual medical diagnosis, because that really determines, and I know there are many cultural issues in between, regardless of knowledge which you have brought out. So knowledge does not translate into early seeking behavior, health seeking behavior. Thank you.
Thank you so much. I just have one question. This is on the social behavior change and communication. This is because of the preconceptions that you have said, as stated, also the cultural beliefs. That is in conjunction with our question. What are your recommendations to these ladies? Because I know social behavior change is a key thing even in our rural setting. So what are your recommendations after the study?
Good. You can allow Daktari, our good Daktari, to respond to those questions, or we can take another question.
All right. Thank you very much, colleagues, for those really very insightful questions. I'll start with what Dr. Kubai asked about the precision medicine. I think for Dr. Kubai and the others, in fact, the Western world is going on the precision medicine, but unfortunately, it's capital intensive. For example, we know very well that the triple negative cancers are more aggressive, and the women who have genes for triple negative cancers, the BRCA genes, BRCA1 and 2 genes, we are not able to actually do this in our country. The BRCA genes, I remember two women I interviewed. One had 2 aunts who had actually breast cancer, and they had passed on, and then grandmother. The other one had got a grandmother and actually a sister who had cancer. Honestly speaking, that kind of family, it means they may most likely have the BRCA1 or BRCA2 genes. But because of the capital intensiveness, I think they could not be able to get advantage of getting that. Like, for example, the genomic typing has to be done, and we have to have a bank for that, and that can be used then to advise women to carry the education that our colleague is talking about here. But I think, again, that is not done. We know the black race, studies in America, the black race is more vulnerable to actually get the breast cancer. And they get it even before they are 50 years old. So the age is actually lower than the whites. Again, that indicates there's some genetical, biological factors. But again, because we are not really, our population, we are not investing in this kind of technology, then the population is not benefiting. But it could be very much, very, very useful. And I think people in genetics really have this kind of information. I think this is what I would say about that. It could be practically very useful. Yes.
I expected the recommendation to be, in the policymaker, we should move away from the normal screening. Because we invest so much, people are traveling all the way to India. The recommendation for our research in this part of the world should be the government to change their approach in terms of review of especially to the clinicians. Well, we have so much to do the normal way for many years, and we are losing a big level. And the other family is affected by cancer. Even if it's not the president, even if it's not by I think we need to
Yes, absolutely true. And of course, we also need to invest in the primary care where we capture these cancers, stage 1 and 2. Because however many cancer centers we build, these women are going to come in stage 3 and 4. It doesn't matter if you're in America or in Europe, you are going to do nothing much if a lady comes stage 3 and 4. But if you can go out there and we have them coming early enough, then even the facilities we have, we can get better survival rates. I think that's what I would say. Now, in terms of the themes, my colleague there, I think these are some of the key themes. But the social networks, the disclosure recipient were a very, very overarching theme that was coming among women. The cultural explanations about cancer, where they attributed cancer to witchcraft, and most of them went to pastors for prayers, was also a very major theme. The inadequate knowledge about breast cancer came also very strongly. Now, about social change and communication, I think my biggest recommendation is that we need to have interventions that are intersectional. I would like to say, and Prof, just allow me, one of the most surprising things that I discovered in this study is that the gender influence on women's healthy behavior. What do I mean here? Women had money, but they believed it's not their role to fund their health care. So they get their cancer actually advancing because they were waiting for their husbands to actually pay for their health care. Because they believed, their gender roles, they believed it's not my role to take myself to the hospital. In fact, they said, "Alinioa ndiye nichunge," if I'm going to quote in Kiswahili. So I was married to be taken care of. So I cannot use my money to go to the hospital. I mean, that was very disturbing to me when I found that kind of a study. It means we also need to liberate women about thinking about their own. So there is cognitive kind of barriers in their head about their role as women, that they can't pay for their health care. So this kind of communication you're talking about is not just enough to tell women about breast symptoms. We also need to have empowerment interventions where they know we liberate them from their own cognitive structures that tend to, kind of self-suppress themselves. Women suppress themselves by the kind of gendered cognitive structures and schemas that actually they have acquired. And this was very disturbing to me when I found that. Yes, so we need interventions that deal with all these factors together. Thank you.
Thank you very much. Again, let us appreciate our Daktari for the good presentation that he has shared with us. Daktari, you've said that you are an adjunct lecturer here. I know we can easily get you. Let us continue having that contact because it is important for us as we develop this very important area of cancers in Meru County. Thank you.
Thank you very much for listening to me. Thank you.
Thank you. Ladies and gentlemen, I think we're getting to our last presentation today at this session. And without much wasting time, allow me to call Zachary Muriuki, who is going to share with us his data on the extent of disaster risk preparedness in informal settlements of Nyeri town. Muriuki, welcome. Take a short period as possible so that we can eventually break for lunch and then be here again in the afternoon to listen to our 3 guest speakers. Thank you. Muriuki, the floor is yours. Please, I would ask everybody to hold on for us. You don't, it is lunch hour, I know, but it's only 15 minutes and then we will be done. Thank you.
Good afternoon. I'm Zachary Muriuki. I am a clinical officer by profession. I am also a lecturer or tutorial fellow, Meru University of Science and Technology. I take this opportunity to thank you because this is a thesis of on PhD in public health, and I thank the Meru University, the organizers of the conference, so that I can also get some insight, and maybe it will help me in improving before I reach the other part. So then I am talking about extent of disaster preparedness in informal settlements of Nyeri town, Nyeri County, Kenya. In the introduction, I tried to first to describe a disaster is a serious disruption of the function of a community or society causing widespread human and material, economic, and environmental losses. So this is according to Patton 2009 and Mike Fad Clark 2006. Urban growth is expected to continue by the year 2030. I think that is, we need to add the 0 there. Approximately 42.5% of Africa's population will live in cities. This presents an unprecedented demand for urban shelter, as more than 100 million new units will be required during next decade to cater for the population growth that is according to the World Bank 2020. Around 1/4 of the world's population in 1990 lived in slums. Over 90% of this urban growth is occurring in developing world, and estimated 70 million residents are added to the urban area of developing country each year, according to SATWAD 2020. In Africa, over half of urban population, 61.7% live in slums. And by 2050, Africa urban dwellers are projected to have increased by 400 million to 1.2 billion. That is the World Bank 2020. The Nyeri town, which is about 150 kilometers from Nairobi city, in the former central Kenya, has 4 informal settlements. The one I have chosen, we have the Gagaridhi, Majengo, Itemere, and then the Mathari, which borders Mathari, and then the north to the south. This is the area where I have chosen to do my study. The problem of the statement, building in the informal settlements are built without accessible established roads, hence the firefighters or any other help that may be needed is not able to come forward. And that is the basis of this study, because it has become a problem in that area. That is the government of Kenya 2015. In 2015-2016, there were 99 fire incidences that were reported in Nyeri County, and 45 or 50% occurred in the informal settlements. That is according to fire brigade report. More to that, majority of the residents live below poverty line, which is about 47%, hence access. According to World Health Organization, is somebody who lives below $1 a day. I don't know, maybe this time the dollar is changing for more, but the standard by the World Health Organization, the person below the $1 a day, that the person we say is poor. 47, the buildings are erected without access of roads. Informal settlements are influenced by shortage of affordable housing, poor government and economic vulnerability. United Nations Habitat 2015. Maybe we are thinking maybe it's going to be solved by the Kenya Kwanza government. County government of Nyeri has disaster reduction committee with a name of settling these people in Nyeri County, according to the Nyeri County report 2016. That is justification. The disaster is increasing, becoming a global concern. Disaster have negatively affected human life. If we are going to look at the land where these people have built, in fact, it is very dangerous because some of these people are even fetching water from the river, just a few meters from the house where they are living. Those are research questions. And the study objectives to establish the extent of disaster risk preparedness among people living in the informal settlements of Nyeri town. The specific objectives to assess the level of awareness on the types of disasters and policies in place to curb disaster among the people living in informal settlements of Nyeri town. Determine awareness of the disaster mitigation measures in place in informal settlements of Nyeri town. To identify the role of stakeholders in disaster management in the informal settlements. Determine the challenges encountered during disaster risk reduction initiative in the informal settlements of Nyeri. That is part of the literature, and this study is guided by 4 theories: the theory of planned behavior, the normative theories, theory of human motivation by Maslow, change management theory of Shields. The awareness on disaster types and policy, most of the people are aware of the disaster, but do not know what to do if a disaster happens. In this case, most of the people, because of the tradition and cultures, the way they live in the informal settlements, some of them don't do anything when a disaster happens, because it's like they are used to living in that particular area, and there are few things that they do that people may not like, and therefore, even sometimes, as we are going to see in the challenges encountered, they just chase the people away, maybe who may be coming to help them. Policies focus on building institutions and developing actions, but the policies lack budgetary support. That is by according to Ahmed 2013. In many countries, and especially Kenya, and the national government and the county government, most of the time they don't have the budget of disaster due to different reasons that maybe we are going to get some in this study. Disaster mitigation measures, urban resilience framework should be expanded to include a wider range of sustainability, according to Wells 2019. Then we have the roles of the stakeholders in disaster management. There is need for collaboration of all bodies like the NGOs and the government to achieve shared reduction initiative, lack of capacity and coordination of the national level, gaps in the legal framework. So in the informal settlements, they have problems, but some of the problems they have, they are just their own creation. So they chase away the donors, according to Karaoke 2015. The challenges encountered, we have the lack of support from the government, lack of community participation, inadequate funding, and lack of that connection, lack of education. And then we have in the disaster risk reduction policies, the type of disasters that, the policies that are there, we have the environmental, and then we have the housing, and then we have the water. These slums, one of the slums is along the Chania River. So there is need for this policy, the water policy. Then we have the compliance, which now we see as we go on. So that is the conceptual framework, and that is the methodology. The researcher, or I applied descriptive cross-sectional study design. The study area was conducted in 4 informal settlements, as we mentioned above. The study population and sample size determination used the Fisher et al. 1998 formula, and it got a sample size of 384. Study population and sample size, the population of the people living in 4 informal settlements was, according to the Kenya National Bureau of Statistics, 94,469. Since the target population was more than 10, the sample size became 384. Sampling procedure at the location level, proportionate sampling method was used. At the informal settlements, all the households were registered in Microsoft Excel sheet. Then a table of random sample was used to generate study participants for each informal settlement. Sample size, according to the informal settlement, is that now according to the sample size that we got at the beginning. Research instruments were constructed based on the operational framework variables, which were derived from the study's specific objectives. We have a semi-structured questionnaire, key informant interview, and informed consent was also used. Data collection, semi-structured questionnaire were used to collect quantitative data and on levels of awareness of the stakeholders and the challenges encountered during disaster risk reduction. Key informant guide was used to collect quantitative data in order to add value to the quantitative data. Data analysis, quantitative data was screened, coded, and analyzed using statistical package for social science, SPSS, version 25.0, and Microsoft Excel for graphical presentation. Inferential statistics were also used, the chi-square. The results were presented in tables and figures. The bias minimization, we had the sampling bias, which is, we minimized using table of random sampling, random numbers during sampling. Interview bias was minimized using standardized data collection tools, and research assistants were trained to obtain data in standardized manner. The ethical consideration, we sought the approvals, Meru University, graduate studies, and then the Nyeri County government, and the Nyeri